Welcome to the next session of She and Rights Live from Women Deliver Conference 2026. She and Rights Live at the Women Deliver Conference 2026 sessions are being hosted at D03 Exhibition Space in Narrm, Melbourne, Australia. All sessions are hybrid, live streamed, and host online and on-site speakers and participants including media. She and Rights is co-hosted by Global Center for Health Diplomacy and Inclusion, SEHDI, and CNS with partners like Women Deliver Conference 2026, International Planned Parenthood Federation IPPF, Asian Pacific Resource and Research Center for Women ARROW, Asia Pacific Media Alliance for Health, Gender and Development Justice APCAT Media, and Health TV Online Nepal. AMR under gender lens. Friends, we know that despite promises made by all our governments for health and gender equality, that is what SDG 3 and SDG 5 say, we are not on track. Less than 58 months are left to keep these promises, but the sense of urgency and purpose is seldom seen when it comes to human right to health and gender equality, both of which are fundamental human rights and are inextricably linked. We cannot dislocate right to health from gender equality. Antimicrobial resistance, or AMR as we call it, is caused by misuse and overuse of medicines in human health sector, animal health and livestock sector, food and agriculture sector, and it is also polluting our environment. We cannot afford any misuse and overuse of medicines in any sector if we are to deliver on SDG 3. A complex mix of biological, social, cultural, and economic factors arising from gender-based inequalities and injustices impact infection prevention and control. For example, the lived experience of girls and women and gender diverse communities show how violence had put them at risk of getting infected or got them infected with sexually transmitted infections, HIV, or have caused unplanned pregnancies. Gender inequalities, harmful gender norms, stereotypes, and tropes have normalized the neglect of health and well-being of girls and women, making them more vulnerable to AMR. It is no surprise that girls and women and gender diverse communities often slip to the last priority when it comes to disease screening or diagnostics, treatment, care, and support. And this is when girls and women are themselves the primary caregivers. Gender-based violence is a gross human rights violation, but progress is abysmally low in reducing gender-based violence. In the last 26 years, the annual decline is a mere 0.2%. How can this be acceptable? It means gender-based violence should have become history by now, and yet this low rate of decline. In Afghanistan earlier this year, the government legalized domestic violence so far as the bone is not broken. Should we be grateful that our bones will not be broken? Or should we be outraged that why women beating is accepted by law? Women want to end all forms of violence against them, including emotional or psychological violence. We want to live with rights and dignity and allow the same for all gender diverse peoples everywhere. Ending all forms of violence against women and girls and gender diverse peoples, ending gender inequalities and injustices, ending ageism are not only human rights imperatives, but also enablers to improve health responses like those of AMR. We cannot let gender equality slip off the radar if we have to prevent AMR and save our medicines that protect us. Let us hope that governments and civil society leaders who meet at the 70th session of the UN Commission on the Status of Women in New York advance concrete progress towards ending violence against women and girls and gender diverse communities, ending gender inequality, and accelerating progress towards SDG 3 and SDG 5 by 2030. Likewise, water, sanitation, and hygiene is critically important as a human right as well as if we are to prevent AMR. With World TB Day coming up, and also as someone from the country with the highest TB burden worldwide, I would like to draw your attention to drug resistant forms of TB. In the year 2000, the upper end estimates showed that we had around 400,000 cases of drug resistant tuberculosis. In 2024, we also had a similar number of people with drug resistant TB. No change. We have failed down the line to prevent drug resistant tuberculosis as the TB bacteria continues to become resistant because of overuse, underuse, or misuse of TB medicines. And to top it all, we were able to diagnose and treat only 1/3 of those estimated to have drug resistant tuberculosis in 2024, as per the WHO Global TB Report of 2025. We can do better. We could have done better years back. We had the science, tools, and evidence to do so, but we could not. If we are to end TB, we have to ensure zero drug resistant TB that occurs due to failure of infection prevention or control or misuse, overuse, or underuse of TB medicines. AMR and other health responses must have a feminist response, which warrants a development justice model based on care and solidarity for each other, where no one is left behind in the truest sense of the words. In 2024, the WHO released its guidance on addressing gender inequalities in national action plans on antimicrobial resistance. And this guidance provides practical recommendations for countries to integrate gender responsive approaches into AMR policies by addressing key gender disparities in the prevention, diagnosis, and treatment of drug resistant infections. Now, without any further ado, for today's opening address, I welcome and invite my friend, mentor, and guide, Dr. Soumya Swaminathan. Dr. Swaminathan serves as chairperson of MS Swaminathan Research Foundation. She is former chief scientist and former DDG programs of WHO and former secretary, Department of Health Research and Director General, Indian Council of Medical Research. She is a very widely respected scientist and director earlier at National Institute for Research on TB, NIRT of ICMR. Welcome, Soumya. Over to you.
Hello, good afternoon. Can you hear me?
Yes, very clear.
Okay. I'm having a bit of a respiratory infection, so hopefully it won't interfere. Thank you so much, Shobha, for that really excellent introduction to the topic that we are discussing today. At first, it may seem very odd. How do these two things go together? That is gender and antimicrobial resistance or One Health. But when you really start thinking about it or looking deeper into the literature, then you see that there are many ways in which AMR is also gendered. And I must say that anything you look at, in fact, if you look with the right lens, you will find that there are gender-based differences. For example, recently we have looked at the impact of climate change and particularly the impact of extreme heat on women and found that most of the reports from India and the neighboring countries show that women are disproportionately impacted, whether it's because of worse access to water, access to food, very difficult work and also home conditions where there is no cooling, no ventilation, and an increase in gender-based violence occurring during the hottest months of the year. And over a period of time, when we look at data over the last 10 years, let's say, and we look at NFHS data from the National Family Health Survey, and we overlay that with climatic data. So if we take districts which experienced recurrent droughts in the last 10 years versus all those which did not, and look at some of the health and nutritional indicators for women and children, you find that there are significant differences. So more women are undernourished in the drought-prone districts. More women are married off early, so more chances of teenage pregnancy. There's less antenatal care. There's problems with immunization services. And most significantly, an increase in gender-based violence, probably related to distress, drought-prone areas. There are livelihood concerns, and could be more migration and so on. So the point I'm trying to make is that one would think that climate change impacts everybody the same way. But while it does impact everyone, no doubt, there are certain very unique ways in which women are impacted, and it's very important to understand. So I think the first thing I'd like to say is that this particular topic, very well chosen by GAMA and very relevant for today, and also throws up the lack of data, the lack of disaggregated data, the lack of granular data on this topic. So many of the things that we will talk about today, there's not a whole lot of data really backing it up, and I think we need more focused research in this area. So let's see the ways in which we could relate gender and antimicrobial resistance. And let's start with intimate partner violence or domestic violence that I just mentioned. Obviously, women are at a much greater risk. Most of the time they are, in fact, the victims or receivers of domestic violence. This is physical or it could be sexual violence. This obviously could lead to more infections. And because their position within the household and the community, they are less likely to seek care for these injuries or infections, late care, perhaps those or inadequate care, self-prescriptions, etc. And these could lead to more complicated or drug-resistant infections. So whether it's sexually transmitted infections or urinary tract infections, reproductive tract infections, pelvic inflammatory disease, all of these linked with sexual violence and an increased risk of antibiotic use. Also, quite often in these cases, follow-up is poor. So the woman may go and seek care and then not really follow up. And so she may have taken just a partial course of antibiotics, incomplete or the wrong doses. So it's also true that in emergency settings, antimicrobial stewardship is often poor. When we talk about stewardship in a hospital, generally the hospital authorities look at it in ICUs or post-op wards. There's a protocol for antibiotic use. But in the case of an emergency room, this may not be practiced as thoroughly. And so you may have a lot of misuse of antibiotics going on. And this in turn could, of course, lead to more resistance, whether it's UTIs or Neisseria or mixed anaerobic infections. Clearly also, domestic violence, which as Shobha said, unfortunately, continues to remain unacceptably high, does impact the access to health or other care by the woman. So there's delayed seeking of care, there's because of limited autonomy and also stigma. And so this again would lead to complicated infections and creates a vicious cycle. Now, in terms of antibiotic misuse, in many contexts, women may receive antibiotics without prescriptions. As you know, many of the infections that occur commonly today are diagnosed only based on clinical or what we call a syndromic approach. So there's no diagnostic test that's performed. And there are many such women's health-related diagnostic tests which currently are lacking, particularly in the primary healthcare system. So in the absence of a diagnostic test, it's often the case that a broad-spectrum antibiotic is prescribed. And this could be dispensed by pharmacies without a prescription, or it could even be dispensed by primary care doctors. So while syndromic approach is a pragmatic approach, what it does do is increase antibiotic exposure and may fuel or accelerate development of resistance. And unfortunately, we don't have surveillance at the community level. So the ICMR's AMR surveillance has been expanding over the years, but it's still limited to tertiary care centers, tertiary care hospitals. And so what we get is a picture which is just the tip of the iceberg. We don't know what is going on at the community level. There are very few studies. So again, that's a gap in knowledge that we have. Now, obviously, in humanitarian settings, conflict and displacement, all this gets much worse. We know that women suffer a lot of violence, and it's terrible to see what's going on around the world now. And this, again, will predispose them to infections. Diagnostics are often limited. Antibiotics may either not be available or maybe even used empirically or misused. If you look at healthcare workers, again, majority of healthcare workers, especially frontline workers in the world, are women, and they also face harassment, they face challenges, they face burnout in the workspace, and all of this could also lead to inadequate or weaker infection control practices or antibiotic stewardship practices. Ultimately, the nurses are the ones who really, I think, determine the quality of care across our hospitals and health centers. And so if the nurses themselves are not looked after well, or they're not in good health, or they're not continuously being uptrained and skilled, then you will find that there's a deterioration in the quality of care, and also their own performance metrics. Again, with women who, let's say, are facing an unwanted pregnancy, they go for an abortion, unsafe abortion. In some cases, they are also at higher risk. So there are these biological reasons of menstruation and not having access to sanitary menstrual products, of pregnancy, of childbirth, of abortion. These are all faced only by women, these health conditions. And therefore, all of these, in fact, predispose. If the care is not right, around menstruation, around pregnancy and childbirth, do predispose to higher risk of infections, and therefore the use of antibiotics. And in India, there's a growing threat of gram-negative infections in the case of maternal sepsis. So what we could do in terms of actions, firstly, is to integrate AMR into one-stop crisis centers. So, for example, in a humanitarian setting, or when there's a displacement, there's a flood, there is a refugee camp or for displaced people, and so on. Or even in urban health clinics, for example, AMR, antimicrobial resistance, needs to be integrated so that when there is a situation where, let's say, there is post-violence care needed, then antibiotic stewardship is very much part of the protocol, and there should be some surveillance data capture and evidence-based antibiotic protocols which are relevant for each geographic location, and that you can only do if you have good surveillance data. So the two actually go together. We also need to strengthen diagnostics. So we need to move away from syndromic algorithms towards a more specific STI, test-guided STI management wherever feasible. We have now so many rapid point-of-care diagnostic tests coming up for respiratory infections. Let's take the example of COVID. I mean, within a year, we had so many different kinds of very good, highly sensitive and specific point-of-care tests. The same thing must be applied to genitourinary infections, reproductive tract infections, and urinary tract infections, so that in a primary healthcare setting, we can make a rapid diagnosis and give the appropriate antibiotic. This will minimize costs, it will improve the outcomes, health outcomes, and it will certainly reduce the development of antimicrobial resistance. The other action that could be taken is to include gender-based violence indicators in AMR national action plans. So recognizing that sexual health and violence services are hotspots for antibiotic exposure and include gender sensitive stewardship indicators. So this is in the AMR National Action Plan. And then, of course, train providers, linking trauma-informed care with national antibiotic use, and address some of the research gaps that I talked about. Like, for example, what's the percentage of resistant STIs among survivors of gender-based violence? What is the pattern of repeated antibiotic exposure in women who experience intimate partner violence? What is AMR burden in those women who have infection after unsafe abortions? So all of this that I've talked about essentially is about how violence against women could be a driver of antimicrobial exposure and equitable resistance risk. And if we look at it from this perspective, it aligns very well, with the One Health approach. And I just want to say a few words about that, because at the MSSRF, of course, we work a lot with women farmers. And as you know, there's been a feminization of agriculture. A lot of the farmers now go to villages. Farming is being done by women, while the men migrate for work. And traditionally, women have always been the ones that looked after livestock and look after poultry or any of the other household animals. They manage manure. They, of course, are also responsible for looking after the children and feeding them, caretaking activities. So when you look at it from an intersectional perspective, that here's a woman, she's also a farmer, let's say a small farmer, who has some livestock and she does some agriculture, and she's in a rural area, and she has a young family to look after, and she's alone because her husband is migrated, and therefore she has less access, to a health center and so on, may have less financial autonomy as well. In such a situation, she would be probably more likely to either neglect infections or take inappropriate treatment. In many parts of the world, we know that people still seek traditional care, and while for minor things, I think this is okay, but very often we see even things like TB, they're presenting very late because they've spent a lot of time shopping for treatment, some from traditional care practitioners and others also from informal health providers who are basically quacks. So any AMR strategy, I think, needs to look from this gendered perspective at the different elements, like again, somebody who's dealing with livestock, for example, certainly, and manure and things like that, can be exposed to more infection. And we know, for example, even TB is a disease that can spread from human to cattle and cattle to human. In fact, nowadays it's much more common for the cows to get Mycobacterium tuberculosis from their human contacts than the other way around. But again, the data on this is very limited. So we need more data on what are the infections that are going around and what is exposure in rural settings, in agricultural settings, because we know antibiotics are used across the board for crops, for poultry, for livestock, for fish, aquaculture, and so on. So again, it's the non-human sector antibiotic use. And we did a survey across a few districts of Tamil Nadu, and we found that most people, farmers who were using these, had no idea what antibiotic it was, whether it was recommended or not, why they were using it, and what were the precautions to be taken when you use an antibiotic. What is the period for which you need to wait, for example, before you can take the milk of that animal. These were all things which were not, they were not aware of. So we've not done any kind of comprehensive studies to look at exposure to the antibiotic in these settings. across all of these different crops, livestock, etc. What is the impact of that on the human beings who interact with them, and whether the use of antibiotics is actually driving antimicrobial resistance in humans. This is something that we need, this pathway of how it impacts is something that still needs to be worked on. So I think I would end by saying that the relationship between antimicrobial resistance and gender is driven by biological factors, by behavioral factors, as well as by things like gender-based violence, taboos, and stigma that occur in society. And we cannot be successful in reducing AMR, but in this case, or preventing more AMR, but in this case also, I would say our equal goal, reducing gender-based violence, as Shobha mentioned in her introductory remarks, and we need to keep speaking up for it, finding the data, putting it out there, and hopefully helping to change policies in the right direction. Thank you very much, Shobha. Back to you.
Thank you, Soumya. Thank you very much for connecting the dots and unpacking how gendered approaches and how gender-based violence makes women more vulnerable to antimicrobial resistance. I'm sure many of us, many of the media persons also, and general public do not see that connect. And thank you for unpacking it so clearly, and also for suggesting concrete solutions, particularly improving diagnostics and healthcare at PHC level, especially for infections like UTIs and others which affect women more. We'll take up the questions later on. There are already a few questions for you, Soumya. We'll take them later. And I now welcome our next speaker, who is like my younger sister, and she is Bhakti Chavan. Bhakti is a member of the WHO Task Force of AMR Survivors. Over to you, Bhakti.
Am I audible?
Yes, you are. Yes.
Yeah. Thank you, everyone. Hello, my name is Bhakti Chavan. I am an XDR-TB survivor from India and also a member of WHO Task Force of AMR Survivors. The main function of this task force is to create awareness and humanizing this AMR issue by sharing real-life survivor stories. I would like to sincerely thank CNS and Gamma for organizing this important webinar on AMR through gender lenses. As AMR survivor and being a woman, I would like to connect this issue with the real life experiences, because AMR is not just a scientific concept, it directly impacts lives and especially women's lives. When we talk about misdiagnosis or delay in the diagnosis faced by the women, one of the most common examples is the urinary tract infections. One of my close family members was suffering from the recurrent urinary tract infection. Each time she visited her family doctor, she was advised a routine urine test. The test showed the pus cell and bacteria present. Every time she was prescribed with a new antibiotic course, which was not helping. However, no culture or DST was done initially. Her symptom kept worsening. Eventually, she consulted a urologist. A urine culture and DST was performed, and the result was shocking. The E. coli strain which was found in her urine culture was resistant to most of the powerful antibiotics. Only few were susceptible in her case. Immediately, doctor put her on 1 month targeted antibiotic course and she recovered completely, but only after months of ineffective treatments. According to WHO statistics, 1 in every 6 urinary tract infections are resistant. Because the UTIs are so common in women, symptoms are often treated empirically without proper diagnosis, leading to prolonged suffering and resistant development. Also, reproductive tract infections in women are frequently overlooked because of their symptoms. such as lower abdominal pains, back pain, fatigue, pelvic discomfort, are often normalized as a menstrual pain. This normalization leads to the delay in diagnosis and proper treatment. In many cases, women are advised to tolerate the pain rather than seeking a medical help, resulting in untreated infection that can progress in chronic diseases like pelvic inflammation, infertility, adverse pregnancy outcome, increased vulnerability to other infections. This is all about misdiagnosis and delay in diagnosis faces by women. When we talk about the treatment of AMR, here I would like to connect this with my personal experience. In 2017, I was diagnosed with a drug-resistant tuberculosis. I took 2 years treatment. I was young, unmarried. This 2 years treatment comes with the daily painful injectables and different antibiotics, which I have to take daily. I faced side effects like my skin tone changed to reddish brown color. From being a fair girl, my appearance changed completely. I stopped looking into the mirror. I lost huge weight. I was looking like a skeleton. This medicine helped me to recover from the drug-resistant infection, but kept me with a lots of side effects. I carry a scar on my neck because I was diagnosed with the extrapulmonary drug-resistant tuberculosis. The change in physical appearance are not easy to cope up with, especially in societies where appearance is closely judged for the woman. I have seen many women in the patient support group that skips medicine because their visual appearance was changing. We need to support such women who are not confident enough to complete their treatment because it indirectly causing the AMR infections and we are losing on antibiotics. Also, the disease like TB, HIV/AIDS carries a huge stigma in our society, especially for the women. In many communities, a woman diagnosed with TB or HIV is judged not only as a patient but as some who has brought shame to the family. Her character, her marriage prospects, and even her ability to being a good wife, daughter, mother is being questioned. Because of this stigma, I have seen many women hide their illness. They delay testings. They avoid going to the clinics. Some takes medicine secretly. Others stop treatment early to prevent family members or neighbors from finding it out. In case of many HIV women, often blame first, even when they get infected from their spouses. AMR is not a gender neutral. AMR strains are circulating in the environment, and if it can happen to me, it can happen to anyone. If we want to fight AMR effectively, we must listen to the women, diagnose them earlier, ensure proper treatment, support adherence, and design policies that consider women's realities. Thank you.
Thank you very much, Bhakti. Thank you for sharing your lived experience and also mentioning the role of stigma, what stigma plays in delaying access to medicines, in delaying diagnosis for women. Thank you very much, Bhakti, for being there.
Thank you. And now we will move on to our next speaker, Dr. Ijyaa Singh. Dr. Ijyaa Singh is a noted antimicrobial resistance prevention advocate, and she is currently serving as the monitoring and evaluation officer or manager at the world-renowned organization called REACT Asia Pacific. Welcome, Dr. Ijyaa Singh.
Hello, good morning, everyone. I'm Dr. Ijyaa. I'm M&D manager at REACT Asia Pacific, and today I will take you through a topic that sits at the intersection of two major global health challenges, AMR and gender. So why do we have to talk about gender? So before we dive into the evidences, let's get our definitions right. As we all know, biological sex, it refers to the physiological and genetic characteristics. While gender is a social construct, the roles, norms, behavior, and expectations that societies assign to men and women. And gender equality in health, it means that both men and women, they have equal opportunities to access services, benefit from policies, and participate in decision making. Not identical, but equitable opportunities. And what are the missed opportunities for learning? So let's start with the workforce. The pie chart on the right, it tells a story. That is, approximately 70% of the healthcare workers, they are most critical to infection prevention and control, are women. Pharmacists, nurses, frontline workers, they are females. Yet the same women, when they step out of their professional roles and become patients or caregivers, they face enormous gendered barrier to healthcare. Consider this quote from one of the patient, that is, I have had 3 children, but I never stepped into the hospital. So think about what that means for her health, her children's health, and her ability to seek appropriate care when infections arise. I want you to read this banner, that is, we cannot do this research without looking at gender, race, ethnicity, and caste. It is a practical research imperative. Gender does not operate in isolation. It intersects with socioeconomic status, caste, race, religion, and geography. Let's now talk about the specific mechanism through which gender shapes AMR risk in low and middle income countries. WHO has formally recognized that the fight against AMR requires focus on gender. In many LMICs, stringent socio-culture norms restrict women's ability to make independent health decisions. A woman may need permissions from husband, mother-in-law, or village elder before seeking care. There is low level of education for women. There is limited health information and networks. That means women are more dependent on informal care. And critically, inadequate watch facilities. They are the structural risk factors for AMR transmission in and resistant development. Women, they are 27% more likely to receive antibiotic prescription in their lifetime compared to men. Not because women are sicker, it reflects a complex interplay of health-seeking behavior, provider bias, and social pressure. Women's lack of economic resources and decision-making power within household means they are less able to complete full antibiotic course, follow-up treatment, or challenge inappropriate prescribing. There is a restricted mobility due to patriarchal norms, which leads to delayed care, which can increase severity of infections and pressure on healthcare providers to prescribe antibiotics. On the exposure side, women are primary caregiver in households. They are managing six family members and therefore indirect contact with infection and resistant organism. They make up 70% of frontline health workers with all the occupational exposure that entails. This is a dual burden. Women are both more exposed to AMR and more subject to the social forces that drive inappropriate antibiotic use. I want you to just look into this visuals because it captures something that normally we cannot. There is access to healthcare, caregiving roles, occupational exposures, and antibiotic use patterns. They are not independent problems. They reinforce each other in a cycle that is very difficult to break without systematic interventions. A woman who lacks access to healthcare delays treatment. Delayed treatment worsen infections. Worsen infections leads to more antibiotic use. More antibiotic use, often self-administered or inappropriately prescribed. It contributes to resistance. So this diagram, I encourage you to use in your own advocacy work, as it communicates the complexity in a very simpler way. Socio-economic inequities and AMR. The question at the center you can see is, how does power manifest itself across social constructs? Power determines who gets quality antibiotics and who gets counterfeit ones. It determines who has clean water to prevent infection in the first place. Power determines whose knowledge of health gets validated and whose gets dismissed. The intersection research gives us the tools to trace these power dynamics empirically and to design intervention that address root causes, not just the symptoms. This is a systematic review, and the findings are: women are significantly more likely than men to receive antibiotics in community settings and are 27% more likely to receive prescription over their lifetime. Now, this needs careful interpretation. For UTIs, there is no significant gender difference. That makes sense biologically, since UTIs are overwhelmingly more common in women. But for respiratory tract infection, where there is no biological reason for women to need antibiotics more than men, we see more inappropriate prescribing in women. This suggests that prescribing decisions are being influenced by social and gendered factors, not just the clinical ones. Provider assumption, patient expectations, and communication dynamics in the consultation room all plays a very important role. Let's talk in detail about urinary tract infection. They are the third most common infection globally, and they are 8 times more common in women, making this perhaps the most gendered concentrated infection we encountered in primary care. The volume of antibiotic use for UTIs is enormous, and the potential for inappropriate prescribing, overtreatment, underdosing, wrong antibiotic choice is significant AMR driver in community setting. However, the picture is actually not simple. The healthcare associated UTIs, they are more prevalent in older males, particularly those with catheters or urological procedures. So while the community burden is female dominated, but the hospital setting shows a different patterns. UTIs, they are often treated as routine, but they are a window into a much larger question about gender, hygiene, health access, and prescribing patterns. This research paper shows here is on gender and antimicrobial using participatory art case studies. It represents an innovative methodological approach. It recognizes that traditional quantitative data alone cannot capture the lived experience of gender and AMR. This method involves community mapping, narrative research, photo voice, which allows communities, particularly women and marginalized groups, to articulate their own experiences of antibiotic use and AMR in ways that standard surveys cannot. The question for all of this is, are our current data system capable of answering gendered AMR questions? And if not, what would it take to build the capacity? WHO recognized the need to take the first step towards better considering gender and equity focused in countries' attempt to address antibiotic resistance. The statement coming from WHO was significant. What does it actually mean to mainstream gender in AMR? This slide gives us the 4 concrete questions to guide the process. First, are healthcare benefits distributed equally between men and women? What are the barriers to access healthcare? Do AMR interventions have differential impact on men and women? Are we causing unintended harm? These 4 questions should be built into every logic model, every evaluation framework, every program review for the AMR work. And what are the strategies for mainstreaming gender in AMR? First, gender disaggregated data. Then community engagement, which involve women, marginalized groups, and informal carer, not just as beneficiaries, but as a co-designer of AMR response. Gender sensitive policies, that is reviewing and revising IPC, AMS, and prescribing guidelines to address gendered barrier. Capacity building of healthcare workers. Intersectoral collaboration, that means connecting AMR with WASH, education, and social protection sectors because gender and AMR both span these systems. Empowerment and education of women. Research and innovation, that is funding intersectional, participatory, and gender responsive AMR research. None of these strategies works in isolation. The power is in pursuing all seven simultaneously, and they reinforce each other. Thank you. I hope this presentation has given you both knowledge and motivation to take gender seriously in your own AMR work. Thank you.
Friends, the glacier of patriarchy will not melt on its own. And perhaps calling it a glacier is not a good analogy, as patriarchy is explosive for our lives like a volcano. But the clarity is crystal clear within us that we have to reclaim the feminist narrative and our long overdue rights, entitlements, and privileges. Gender inequalities and injustices must end with us.